I and Dr. Murli are going to talk about the stroke management. I'll be talking about mechanical thrombectomy in basilar artery occlusion. So specifically basilar artery occlusion, I'm not going to talk about the anterior circulation, which involves ICA and MCA. And Murli is going to talk about the surgical decompression in stroke management. So we look at the basilar artery. This basilar artery is the neurologist's equivalent to the cardiologist's left main coronary artery. Occlusion of either artery can be fatal without rapid reperfusion. The evidence for endovascular treatment for acute basilar artery is limited to 2 RCTs till May 2022. So mind it, till May 2022. Evidence for EVT for BAO is limited only to 2 RCTs. That is basics and best. Basics is called as Basilar Artery International Cooperation Study. Best is Basilar Artery Occlusion, EVT versus standard medical treatment. The trials concluded EVT did not differ from medical therapy for the primary outcome or a favorable modified MRS, that is modified ranking scale, at the end of 90 days. But registry data supported its use. Basics and best. The RCTs were hampered by select enrollment, slow and low recruitment, large number of patients treated outside of the protocol, high crossover rates, lack of advanced imaging, example CT perfusion, MRI stroke protocol. Most of the places they were doing only plain CT, because this plain non-contrast CT has limited sensitivity to assess strokes involving post-circulation. Outcome was disappointing in spite of high rates of recanalization. Attention! This is a trial of EVT of acute basilar artery occlusion. Another is BAOC. BAOC is basilar artery occlusion Chinese endovascular trial. The results of these trials presented at European Stroke Organization conference in May 2022 indicate that EVT, that is endovascular treatment, is superior to medical management for selected cases of basilar artery occlusion. Attention trial within 12 hours of symptom onset, and BAOC trial 6 to 24 hours from symptom onset. Except basics, all other 3 trials conducted in China, which is known to have higher degree of patients with intracranial atherosclerotic disease. These trials conclude saying mechanical thrombectomy is associated with lower rates of disability and death in basilar artery occlusion, despite an increased risk of symptomatic ICH. So these are the trials I have to talk about, and thing is, this is what the scenario worldwide. Till May 2022, there was not a good response for mechanical thrombectomy in basilar artery occlusion. But we have proved with our small study otherwise here. That's what I'm going to present. Case number 1. 25-year-old male admitted with sudden onset drowsiness, weakness of left arm and leg, and slurring of speech since 18 hours. So that is very much out of window period for thrombolysis. No comorbidities, BP 130/80, NIHSS, that's National Institute Health Stroke Scale, was 14. So the scale is like this: 0 to 4 mild stroke, 4 to 14 moderate stroke, 15 to 20 moderate to severe stroke, above 20, 25, and up to 42, maximum is 42, is a very severe stroke. So this NIHS is 14, moderate stroke. So MRI brain, acute infarcts in the left thalamus, right midbrain, and bilateral cerebellum. Severely narrowed, occluded distal right vertebral artery, distal basilar artery, and bilateral superior cerebellar artery. So here you can see bilateral cerebellar infarcts. That is left thalamic infarct. This one, a right midbrain infarct. MR angiogram showed basal artery top occlusion. DSA, there's a digital subtraction angiography confirmed basilar top occlusion, and he was taken up for primary thrombectomy, 18 hours after stroke onset. 18 hours of stroke onset. So if you look at this, that's the DSA showing distal basilar artery occlusion. Proximally it is patent, here it is occluded. So these were the clots retrieved from the basilar artery. If you look at this of the clot retrieval, a very good forward flow. Basilar artery is very well made out, as well as the PCAs, right PCA, left PCA, and the distal perfusion is also good. So 3 days after thrombectomy, see, he is trying to lift the hand, responding to command. 1 week after thrombectomy, he is more stabilized. Still is on rail tube. Why? Because any bulbar involvement, any brainstem stroke can have bulbar palsy. So there will be aspiration and swallowing. That's why rail tube. Still is on rail tube even after 1 week. 14 days after thrombectomy, probably is more stabilized. We could make him stand with support, and there is no rail tube. At this juncture, he was able to take orally. And 45 days after thrombectomy, when he came for first review, this was the status. He is walking without support, with minimal limp. 90 days after thrombectomy, when he came for second review, his MRS was 0. 0 means no deficit. MRS again is modified Rankin scale. Rather, 0 is no deficit, 1 is minimal symptoms, no deficit, 2 is minimal symptoms and signs, 3 is deficit, the minimal to moderate deficit, and he is able to walk with little support. 4, MRS 4 is walking with maximum support, and 5 is confined to bed, and 6 is dead. So if you take that score, 0 is almost nil, no deficit. So next, we'll go to the next case. Basilar artery thrombectomy with angioplasty. Previously, we did only thrombectomy. Now we are associating with angioplasty. So 50-year-old male admitted with the sudden onset giddiness, slurred speech, and left hemiplegia since 9 hours. It's 9 hours out of window period for thrombolysis. So it was hypertensive and irregular treatment. BP at admission was 160/100. Chronic smoker and alcoholic. NIHSS 12. So moderate stroke. MRI DW, diffusion weighted MRI showed right pontine infarct. MRA, that is MR angiogram showed basilar artery occlusion full length. It's called LBO, large vessel occlusion. Taken up for direct thrombectomy. Yeah. If you do thrombectomy after thrombolysis, that's called bridging therapy. Here he is presenting after 9 hours. So no other go, we have to go for direct thrombectomy. Clots retrieved from distal basilar artery, proximal basilar artery showed tight stenosis 99%, for which angioplasty was done. 50% opening achieved with reasonable flow, so stenting was not done. 7 days after thrombectomy, we could make the patient walk. So look at this. That is the MRI, diffusion weighted, showing large pontine infarct. And that's called ADC of MRI showing the infarct over the same area on the pons. And MR angiogram showing the total occlusion of the basilar artery. So there is a DSA. Again, see, that's the basilar artery which is not visualized. Total occlusion of the basilar artery. That is the stent in situ. So these are the clots retrieved through the stent retrieval. So after the clot retrieval, you could see the basal artery nicely, distally. But what's happening? Proximally, there is stenosis. So if you look at this, almost 99% stenosis proximally. So with the angioplasty, we could open the vessel and good forward flow with distal reperfusion. So 3 days after thrombectomy, yeah, we could make him rather ask the patient to lift his hand. He is lifting, obeying commands. 4 days after thrombectomy, he is more stabilized. He is made to sit up in the chair on raised tube. As I told you already, because of the basilar occlusion, there is a bulbar palsy, so he is on raised tube. So 7 days after thrombectomy, we could make him stand, but still he is on rails tube. 14 days after thrombectomy, we could make him walk with the support, and rails tube is removed. He was taken orally. And 45 days after thrombectomy, MRS is zero. Zero means no symptoms, no signs, symptom free. So this sort of improvement you can get only with thrombectomy, the basilar artery occlusion. Another case, same basilar artery occlusion, direct thrombectomy done here also. 42 years old female admitted with sudden onset giddiness, loss of consciousness, vomiting, and right hemiplegia since 4 hours. 4 hours means within, very much within the window period of thrombolysis. No comorbidity, BP 130, 70. Even though within the window period, we did direct thrombectomy, the reasons mentioned below. MRI, NIHS 18, again moderate stroke. MRI brain revealed infarcts in the midbrain, pons, left thalamus, cerebral peduncle, and superior cerebellum. MRA, total occlusion of basilar artery. As the relatives were willing for only one procedure, she was taken up for direct thrombectomy. We offered first thrombolysis, then thrombectomy, bridging therapy, but they were willing for only one procedure. So we went in for direct thrombectomy. DSA showed occlusion of the distal half of the basilar artery and bilateral PCA. Clots retrieved from basilar artery. Post-procedure injection showed normal blood flow, basilar artery and bilateral PCA. TC, thrombolysis in cerebral infarctions called TC, was 3. We say 0, 1, 2, 3. 3 means very good reperfusion, 0 no perfusion, 1, 2, 3 in between. A good recanalization reperfusion achieved. We could make the patient sit up in 3 days and make her walk with support in 7 days. She had right supranuclear upgaze palsy due to left rostral midbrain infarct. Trials tube and catheter everything removed on the 7th day and discharged on the 8th day. Again, going back, see, NIHS 18. 18 means moderate to severe stroke. But still, within 7 days' time, we could remove everything and make the patient sit and stand. Patient at the time of admission, right hemiplegia, aphasia, and weakness of left side also, and unconscious, responding only to painful stimuli. MRI showing, see, that's the left midbrain, rostral midbrain infarct, right pontine infarct, large right cerebellar infarct. That is left thalamic infarct, infarcts everywhere. ADC showing the infarcts of the same area, left rostral midbrain, pons, and cerebellum. So if you look at this, the basal artery supposed to be here is not seen, totally blocked, thrombosed. So this DSA, that's the injection through the left subclavian. You can make out the vertebral, but here there's a basilar occlusion. So basal artery is occluded, same, and stent retriever in situ. After the retrieval of the clot, we can make out the basal artery. It has opened up totally nicely, and PCS, posterior cerebral artery, is also very well reperfused, as well as distal, very good distal reperfusion. This is called TC3. So very nicely reperfused distal vessels in the posterior circulation. So these were the clots retrieved from the basal artery through the stent retriever, long clot and the smaller clots. 7 days after thrombectomy, look at the patient. We could make the patient walk with the support just in 7 days. Right tube is removed. And this is what I told you, left rostral midbrain infarct, so right supranuclear upgaze palsy on the right side. 30 days after thrombectomy, MRS was 3 in the sense you could make the patient walk with a little support, but that was the improvement we had after 30 days. So this was the patient for whom we did the bridging therapy. As I told you already, this 56-year-old male admitted with sudden onset headache, vomiting, loss of consciousness, and tetraparesis since 5 hours. So very much within the window period. And admission NIHSS 25. So if you look at this, 25 to 42 very severe stroke, and prognosis very bad, especially in posterior circulation strokes. MRI diffusion rate showed large contomedullary infarct, bilateral cerebellum, thalamus, occipital infarct, everywhere infarcts. MRA total occlusion of the basal artery, thrombolyzed with consent. Since it was large vessel occlusion and large clot burden, Guarded prognosis explained. According to the guidelines, large point in infarcts, etc., thrombectomy may not be beneficial and risky because of reperfusion injury. We explained everything to the relatives and they were willing to take up the risk. 4 hours after thrombolysis, thrombectomy was done. Clots retrieved from the basilar artery. Underlying stenosis of both V4 segments of vertebral arteries. Right vertebral-basilar junction, stenosis was at 70%. For which thromboplasty done, good forward flow resumed. Patient did not show any improvement the next 7 days, but slowly improved since then. And at 30 days, we could make him sit up in the chair. Right hemiparesis, dysarthric and dysphagic after 30 days. But look at this 25, NIHS was 25, very severe stroke. So, patient at the time of admission, he developed respiratory paralysis also, so he had to be tracheostomy was done and he had to be intubated, else he was situ and responding only to painful stimuli. Large left pontomolar infarct and cerebellar infarct, bilateral thalamic infarcts, basilar artery again. These are the ICAs, internal ICA. This basilar artery, the site of the basilar artery is not visualized at all. So is DSA through the left subclavian. If you look at this, the V4 occlusion of the left vertebral artery, that is the V4 occlusion of the left vertebral artery. That is the V2 occlusion of the right vertebral artery. Both the vertebral arteries are occluded, but somehow we could negotiate through the left vertebral artery and injected. We can make out the stenosis. After the clot retrieval, we could make out the stenosis. For which angioplasty done, so good forward flow resumed, and this is called TC2B. It's not TC3, not full recanalization, but still the clots retrieved, and 30 days after thrombectomy, MRS was 3. 3 in the sense, rather at a point we could make him walk with support on either side. And he further improved. Probably after 90 days, he could walk without support. So probably this is my last case. Here I would like to explain about the disease association. What do you mean by that? See, CAD and CVA and CVD, that is cerebrovascular accident and cerebrovascular disease. Coronary vascular disease and cerebral vascular disease can be associated in the same patient. Here, this patient had basilar artery occlusion, bilateral vertebral artery osteal stenosis, both vertebral arteries, and associated MI, myocardial infarction. At one time, he went in for ventricular tachycardia. He went in for cardiac arrest, revived, and I show you the rest of the things. 76-year-old male, a sudden onset of right hemiparesis and third switch since 8 hours. So since 8 hours, but he was thrombolized outside and referred here. He was thrombolized within the window period and referred here for further management. Known diabetic and hypertension treatment, worsening of symptoms after reaching here. When we received the patient in the emergency room, he was actually awake and responding and conscious. But in 1 hour's time, he started deteriorating and he really went in for respiratory distress. So CT brain done outside showed left PCA infarct, but MRI done here showed hyperacute infarct in the pons cerebellum and left occipital lobe. MRA, total occlusion of the basilar artery. So no other go, we have take him up for mechanical thrombectomy. That time cardiac status was normal. So DSA showed hypoplastic right vertebral artery with the critical osteal stenosis and left vertebral artery occlusion. And the clots retrieved from the basilar artery, left vertebral osteal stenosis was persistent, for which plasty was done. Post-plasty, 5 minutes check angio showed near total occlusion of the left vertebral artery, ostium, and stenting was done for that. So here, basilar artery occlusion, bilateral vertebral artery is occluded, left vertebral artery osteal stenosis. We dilated after the clot retrieval. After dilatation, the restenosis, so stenting was done. Fourth POD, he developed sudden ventricular tachycardia and asystole in ICU due to myocardial infarction. Luckily, the intensivist was standing by the side. Meanwhile, he noticed sudden ventricular tachycardia on the screen and followed by asystole. He immediately did the cardioversion and was cardioverted. Echo at that time showed severe LV dysfunction 30 to 35. Probably he developed acute MI that time. And slowly recovering, weaned off the ventilator 10 days later, we could make him sit up in the chair in another 10 days and stand with support followingly. MRS was 4 at the discharge. So he was a patient. When we received, the patient was conscious. Actually, he was thrombolized outside, and here he deteriorated, and we had to put him on ventilator support, etc., etc., and the thrombectomy done. So this was a scan done outside showing left occipital infarct alone, nothing else. So they thrombolized. But here, since he deteriorated, we did MRI, showed right pontine infarct, left cerebellar infarct, this one. And of course, this was seen in the CT also, left occipital infarct. So again, basilar artery, not visualized. And if you look at this, right vertebral critical osteal stenosis. So that is the vertebral artery, very faint, but the ostium is stenosed. And left vertebral artery, not at all visualized, and severe osteal stenosis. Somehow we could go through the left vertebral ostium and basilar artery occlusion is made out. After the clot retrieval, now the basilar artery opened up nicely and we can make the PCS also open it nicely. After the clot retrieval, if you look at this, after opening the ostium, there is a stenosis at the origin of the vertebral artery. So after the clot retrieval, again restenosis of the vertebral artery, for which stenting was done. And after stenting, yeah, good forward flow of the vertebral artery. And if you look at this now, almost IC is 3. There is a very good reperfusion distally. So basilar artery, PCA, distal artery is very good perfusion. So this patient, we could make him sit up in 10 days time with all these complications, revived from the cardiac arrest. And another 10 days, 25 days later, we could make him sit up in the chair. And in a month's time, we could make him stand and make him walk with support. So total number of cases here, we have done so far 31 cases of basilar artery occlusion. And the total EVTs, of course, including anticirculation, more than 60. And thrombolysis with EVT, there is bridging therapy 9, direct thrombectomy 22, basilar artery occlusion. Out of symptomatic ICH, intracranial hemorrhage 3, mortality 2, 1 with ICH, 1 with associated MI. So the good outcome in basilar artery occlusion depends upon the stroke risk factor, stroke severity. There is more the NIHS score, poorer the outcome. Age, higher the age, poorer the outcome. Respiratory stability, the respiratory distress, poor outcome. Thrombus length, longer the thrombus, poor outcome. Atherosclerosis, stenosis versus embolic occlusion. Embolic occlusion, prognosis better. Collateral status, there is leptomeningeal vessel distal collaterals if they are present. Outcome is good. All these factors are important, and patient selection for EVT in basilar artery occlusion to minimize the incidence of fetal recanalization. So, concluding, small number of patients involved in our study shown good clinical outcome with endovascular treatment basilar artery occlusion. As I told you already, so these things came into light worldwide only May 2022. Till that time, no one was agreeing for this EVT in basilar artery occlusion. But even now, these are the different papers published in neural journals telling we need more RCTs comparing patient selection strategies with advanced imaging techniques and concomitant medical therapy to prove that EVT is beneficial in BAO. This is what world leaders say, but in our small study, we have proved beyond doubt that EVT is good in saving life. Number one, saving life, and further to improve the neurological status in the following 30 to 90 days. And some cases, the recovery is really marvelous, very good. They become symptom free. So we conclude saying that endovascular treatment is very useful in basilar artery occlusion. Thank you. So, so now I request my colleague Dr. Murali to talk about surgical management of stroke. Dr. Murali.
Thank you, Dr. Ashokan. So we'll now go on to the second part of the webinar, which is the role of surgery in the management of stroke. I'm Dr. Murli, Senior Consultant Neurosurgeon in Ramakrishna Hospital. In, in stroke, it's a rapidly developing clinical signs of focal or global disturbance of cerebral function with symptoms lasting 24 hours or longer, whose cause is the vascular ulcer. Now, if you look a little bit into the history of stroke, it started even at the time of Hippocrates, who recognized that the occlusion of stout carotid arteries causes loss of consciousness. We've come a long way since then, and now we have various advanced technologies, both for diagnosis of stroke and for its management, like CT, MRI, angiography, and now interventional angiography is also plays a role in the management of stroke. Now, stroke is a major public health burden and will continue to increase as people live longer. Now, if you look at the worldwide mortality and morbidity, India stands somewhere in the middle. We are intermediate between the advanced Western countries and the large parts of Africa, where the morbidity and mortality is very high. And India is somewhere in the middle. Now, if you look at stroke, we all know that there are two broad classification in stroke, that is ischemic stroke and hemorrhagic stroke. Ischemic stroke occurs for about 80% of cases, and about 90 to 20% of cases are hemorrhagic stroke. Now, we are seeing more and more of cerebral venous thrombosis, which at present occupies about 1 to 2% of stroke cases. So there are arterial strokes, as you can see on the right. This is a CT scan of a large left MCA artery infarct. There are other diseases also which can produce infarction, like vasculitis, emboli from the heart, moya disease, metabolic disease, etc. Now, if you look at hemorrhage, majority of cases are related to hypertension, and this is the classic left basal ganglia bleed due to hypertension. Other causes include bleeding diathesis, AVMs, aneurysms, and subarachnoid hemorrhage can also cause bleeding in the brain, which is due to aneurysm, dissection, trauma, and neoplastic. The third variety is venous, which can produce cerebral venous thrombosis and hemorrhage. So, what are the surgical procedures in stroke? Now, as we all know, stroke is primarily a medical problem, and medical treatment occupies a large part of the treatment of stroke. But there are instances where, beyond medical treatment, patient continues to deteriorate, and then there is a role for surgery. Now, this can be divided into two types. One is therapeutic and one is prophylactic. Now, therapeutic is where the patient continues to deteriorate after medical treatment, and there is a large infarct with mass effect, and then you do a decompressive craniectomy. For hemorrhagic strokes, we can do a craniotomy and hematoma evacuation. And sometimes, if there is a large hydrocephalus, then we can do an external ventricular drain or EVD. Now, prophylactic. Prophylactic means we do the surgery to prevent further strokes, for which the classical surgery is carotid endarterectomy, where the stroke occurs because of plaques in the origin of the common carotid and internal carotid, and we can open the vessel and remove the plaque, thus preventing future strokes. The other surgery is arterial bypass surgery in Moyamoya disease, etc., where they occupy a small portion, and I'll just touch upon them. Our primary concentration will be on decompressive craniectomy and hematoma evacuation. Now, what is the rationale for decompressive craniectomy? Why do you want to do it? Because stroke is not a static phenomenon. Stroke is in dynamic evolution. That means on day one, the stroke, if you look at a CT scan, there'll be a very small hypotensity or even a normal scan at the time of admission, but subsequently the stroke manifests itself and develops edema and then develops mass effect. So this is what causes mortality and morbidity. And in decompressive craniectomy, a significant proportion of the skull is surgically removed and dura opened. This reduces the intracranial pressure and prevents secondary damage. So there are two reasons for doing decompressive craniectomy. One is life-saving. If you reduce the pressure, then life can be saved. The second one is preventing more damage due to the stroke. So both these reasons justify a decompressive craniectomy. The patients which are most benefited are those with malignant middle cerebral artery infarction and large cerebellar infarctions. Cerebellar infarctions also, surgery has got a big role to play to prevent coning and compression of the brainstem. Now here is a slide that shows how the intracranial pressure reduction, the intracranial pressure comes down as you do a craniectomy. Now, as you know, the skull is rigid and therefore cannot expand. So if the content, the volume inside the skull increases, then the pressure also increases. So to increase the volume of the skull, intracranial content, we take off a portion of the skull, whichever side the stroke is, and then open the dura. Once you do that, the removal of the bone flap reduces intracranial pressure by 66% from 30 to 10 millimeters mercury, followed by a further 50% reduction to 5 millimeters mercury after dural opening. So let's look at a few scans. Now here is a scan on day one. You can see that there is a large hypodensity, but there is no significant mass effect. And this is how the patient presents. He may even be conscious and talking because it's a right-sided stroke. And then on day two, the patient starts becoming drowsy, and if not treated, he will go into a coma. So this is the stage where there is a mass effect and midline shift to the opposite side. So this is the correct time to intervene and remove the bone, do a craniectomy, and open the dura. So what this immediately does is it creates a space here for the brain to bulge, and it bulges onto the craniectomy defect rather than to the opposite side. Now you can see here in the scan that all the sulcal spaces are reduced here, but once you do the decompression, the sulcal spaces open out and the pressure on the contralateral side and the ipsilateral side is reduced very much. Same way, this is for a cerebellar stroke. Now you can see that there is a ischemia of the cerebellum here on day one, day two, and day three that we do a decompression. So this ischemia of the cerebellum causes a mass effect, expansion of the cerebellum, which compresses the fourth ventricle here. This is the brainstem, and you have the fourth ventricle here, which once it is compressed, it produces a hydrocephalus. So now you can see that gradually the ventricles increase in size, and that also can be life-threatening. So once you do a decompression, then the pressure on the ventricle also comes down and hydrocephalus is reduced. So how do you do this? What is the surgical technique for doing a decompressive craniectomy? So for a supratentorial craniectomy, you do a frontotemporoparital craniotomy. Patient is in the supine position, head rotated to the contralateral side. I'll show you the diagram. It will make it easier for you to understand. So this is the patient, and this is on the right side. You do a curvilinear or question mark type incision, which you can make a large craniotomy with this. So you make the craniotomy like this, you take off the bone, and then you open the dura. Now, once you open the dura, you can see that there is malignant cerebral edema here, and there is bulging of the brain outside the craniectomy defect. So this is how the infarcted brain will look like once you open the dura. But once you open the dura, the pressure, intracranial pressure, immediately drops, and that is life-saving and also reduces the morbidity. Okay, now these are just a group of trials which show that doing a hemicraniectomy is very useful in the management of malignant MCA infarction. So there is an absolute 52.5% mortality reduction, and in some studies the mortality reduction has been from 88 to 47%, and also significant reduction in morbidity and disability. For a suboccipital craniectomy, which we do in cerebellar strokes, you put the patient in prone position, you do a unilateral or midline incision depending on whether it is a bilateral or a unilateral stroke, and I'll show you the pictures. You can see that this is a midline incision. Sometimes you can do the incision here also if it is a unilateral one, and do a decompression bilaterally or unilaterally and remove the bone and then open the dura. So this way the pressure inside the posterior fossa reduces drastically, thereby saving the patient's life, and also hydrocephalus can be reduced. So that is as far as surgery for ischemic stroke is concerned. Now we'll look at intracerebral hematoma as a cause of stroke, for which we can do surgery. Now intracerebral hematoma is mainly due to hypertension, AV malformation, and we see a lot of patients who are on anticoagulants for various reasons, including heart problems and other causes, and they can develop an intracerebral hematoma. Of course, aneurysms can also produce intracerebral hematoma, which is a different topic altogether. Now, what are the locations primarily due to hypertension? The most common is a basal ganglia bleed, either right or left. You can get lobar bleeds, that is those involving the frontal lobe, parietal lobe, occipital lobe, cerebellum, and the brainstem. So all these locations you can get an intracerebral hematoma. Now the indications for surgery. When do you operate on? All hematomas obviously do not require surgery. If they are small in size and patient is stable, then there is no role for surgery. It will be a medical management. But when the hematoma becomes large and produces marsh defect and midline shift, then that is where the role of surgery comes in. So let's have a look at it. What are the types of surgeries that are available for hemorrhagic stroke? You can do a decompressive craniectomy as before, remove the hematoma. Then you can use endoscope to make a small cortical incision, introduce the endoscope, and remove the bleed. Or you can do something called a mini craniotomy. You don't have to do an extensive craniotomy. You do a mini craniotomy and remove the hematoma. So these are all various options that are available for surgical management of intracerebral hematoma. Now here is an example. This is a CT scan, which is a large basal ganglia bleed on the left side. Now after surgery, once you do the craniotomy and evacuate it, this is a small little residual bleed that is left. This won't do any harm, and gradually this will get absorbed. But look at this the midline shift, the ventricles come back, and midline shift is restored, and the patient will become conscious and talking after that. Now, previously we used to wonder whether we should do this on the left side. Right side, fine. Patient will have a stroke, only weakness on the left side, but patient will be conscious and talking. But on the left side, all these factors, whether speech, understanding, comprehension, memory, all of these can be affected. So on the left side, you have to be a little cautious while prescribing surgery. But now more and more people we are doing on the left side, and we do have significant good results even on the left side. So that is the surgery for hemorrhagic stroke. Now, carotid endarterectomy, as I mentioned, is prophylactic. That means you do it to prevent further strokes, and this is done when there is a stenosis of 70 to 99% of the internal carotid artery at the origin. The ACAS study, the asymptomatic carotid artery stenosis study, shows that asymptomatic patients with 70% or more narrowing reduces the 5-year stroke risk significantly. How do you diagnose asymptomatic stroke? You can do a carotid Doppler study, and other investigations include CT angiogram or an MR angiogram. So this is the procedure that we do for a carotid endarterectomy. This can be done under local anesthesia or general anesthesia depending on the patient. And what we do is we clamp the arteries on both sides, and has to be done in a quick procedure where we open up the internal carotid, common carotid artery and remove the plaque, and then suture the artery back. Now, what are the complications? Of course, any surgery is not without its complications, and the major complications, you can have myocardial infarction, hyperperfusion syndrome, nerve injury. You can have a perioperative stroke, which is exactly what we are trying to prevent, and but the incidence is very low. Then you can get restenosis and death. So these are all complications that can occur, but they are very small in nature. So the surgery for carotid endarterectomy is well established and is now standard of treatment for prevention of future strokes. Now, cerebral revascularization. This is done in patients with ischemic stroke, which is ischemic in origin rather than thromboembolic. This procedure was first introduced by Yasargil in 1969, and there have been a lot of controversy whether we should do it for every stroke or not. And now we don't do it for every stroke. We do it only for very, very selective cases where cerebral revascularization will redirect the blood flow for those patients who require it. Now, what are the indications? If there is an extracranial atherosclerotic occlusive disease, ICA occlusion, MCA occlusion, vertebrobasilar occlusion, vasculitis, and Moya-Moya disease. This is the diseases where this procedure is indicated. A contraindication is if there is a large stroke involving the entire vessel territory, say an MCA, large MCA territory, then bypass can precipitate hemorrhage. So those are contraindications. Now, more recently, we are seeing more and more of cerebral venous thrombosis rather than arterial thrombosis. This entity of cerebral venous thrombosis is becoming more common, and there is a role of surgery for that also. Now, if you look at this, what is cerebral venous thrombosis? This is thrombosis of the cerebral veins and the venous dural sinuses. So if you look at the brain venous drainage is made up of superficial cerebral veins, deep cerebral veins, and all of them drain into the dural venous sinuses. So you have the superior sagittal sinus, the sigmoid sinus, and these drain back into the inferior, into the superior vena cava and reach the heart. So various dural sinuses can get thrombosed at any time. And this occurs in about 0.5 to 1% of stroke. So we should keep this in mind when we are investigating a stroke patient. They are more common in younger population and more common in women. So here is a classic example of a stroke or due to a venous thrombosis. So as you can see here, this is the sagittal sinus, and most of them, the bleed or the infarct will be adjacent to the sinus. So this is a clue that you are looking more of a venous sinus thrombosis rather than an arterial thrombosis. And eventually an infarct can bleed and produce a hematoma also along with that. In untreated cases, mortality ranges from 13 to 48%. And mortality is mainly from raised intracranial pressure and unilateral herniation. So decompressive surgery is life-saving and reduces mortality and morbidity. Now, the mainstay of treatment for any venous thrombosis is heparin and anticoagulants. So the question arises, so when you're already putting the patient on heparin, then should you or can you operate? Now, we have found that even with heparin, if the patient deteriorates, then that leaves us with no other option except to go for surgery. So even those who have been on heparin, and if they continue to deteriorate, we go ahead with surgery, stop heparin for a day or so, and then we go ahead with surgery and restart the heparin maybe 24 to 48 hours after surgery is over. And what is the type of surgery we do? We do decompression in most cases, remove the hematoma in some of them, and if necessary, hydrocephalus is there, we do an EVD or a VP shunt. So the indications for surgery in CVT is symptoms of raised ICP, deteriorating sensorium, progressive neurological deficit, and not responding to heparin and anti-edema measures. So here is an example of a patient who came with a left parietal bleed. Now you can say that, how do you know this is due to venous thrombosis? So this may look like a bleed from an AVM also. It may look like this. So when you do an angiogram, either CT angiogram or a MRI angiogram, you can pick up the sinus thrombosis. And you can do a decompression, which will reduce the intracranial pressure. And subsequently, patient does very well. This is another example where you can have a bleed which is due to a sinus thrombosis. So when do you do it? Early intervention is very, very important. There is no point in operating after the patient's pupils dilate and things like that. So we should catch it early and offer decompression when the patient is still in a semi-conscious or unconscious state, ideally. Definitely when one pupil dilates, there is a definite indication for going ahead and doing a decompression. You can do an external decompression, which is removal of the skull and opening the dura, and you can also do an internal decompression, which is removing the clot itself. So this is how a post-op picture looks like. You can remove the bone, open the dura, and then immediately the brain goes back into the defect, relieving the pressure on the ventricle and restoring the midline shift back to normal. Now this patient, we continued with the low molecular weight heparin post-op, and he walked home after 15 days. So in lot of patients, the surgical results are very good. So the outcome depends on careful selection of cases, early intervention, continue the heparin, and these patients do very well. So the take-home message today is there is a definite role for surgery in stroke with intractable intracranial hypertension. Early intervention leads to good outcome in a majority of cases. Thank you so much for your patient listening. And I thank you one and all for joining this webinar, especially on a festival day when all of you will be busy. On behalf of Dr. Ashokan, myself and Sri Ramakrishna Hospital, we thank you all for joining us on this seminar. Thank you.